thank Mark. I want to thank Ryan and the team. I think this is a phenomenal effort that we are underway. And I want to share with you the fact that I happen to be the second chief executive for this agency. We're going through a major cultural change. That's for another story. Our agency is Start Treatment and Recovery Systems in Brooklyn, New York, headquartered in Brooklyn, and I'm the newly minted over a year chief executive. And I come to this because I've trained in internal medicine, a fellowship in endocrinology. Some people might say, well, what went wrong? Why are you in addiction medicine? But reality is the fact that where I lived, where I worked, even in the hospitals, it kept coming into my world. Any of my friends, but for the grace of God, I would not be here because of the fact I've come from neighborhoods where it's quite prevalent. I'm going to share with you something that has been part of our cultural change in our agency. But before I do that, I'm going to share with you why we did this and why I became involved. In the last 15 years, I've been focusing more on health services research, partly because of the fact that if we find the most phenomenal medication, the most phenomenal behavioral intervention, we still have to answer the questions of why and how they're used. In health services research, you ask the questions about, is it available? Is it utilized? What is its effectiveness? And obviously, we're interested in cost. These are the type of things that are really critical in healthcare no matter what setting you're in. In fact, it sort of reminds me, my grandmother, when we all have grandparents who tell us that to stay in school, the reading, writing, arithmetic, those 3 R's. In health services research, I've come to appreciate things that motivate providers are also R's. This time 4 R's: reimbursement, regulation, reinforcement by colleagues, and risk management. If you look at what in fact motivates providers, it's usually 1 or more of those R's. So for that reason, we pursued the campaign of trying to find out the impact of electronic medical records. So I'm going to go through an agenda that's going to be quite brief. I'm going to talk briefly about the promise. Talk about some of the roadblocks that we experience as well as others. Talk about some ways to resolve these roadblocks and end up with some recommendations. The promise, we've heard this in a number of pronouncements, both in the public sector as well as in many professional groups, that it has the promise to improve quality, has the promise of decreasing costs in the long term. And until 2006, it was rarely used outside of primary medical care or hospital settings. We began it in 2006 largely because we received a research grant from NIDA. That was the motivating factor, quite frankly. And we often don't think about research motivating the care or changes in care delivery. The roadblocks are many and still exist. And there continues to be conflicts between data requirements between various government agencies. For example, looking at demographics. The CDC has a different way of looking at demographics than SAMHSA. So if you are providing care, receiving care from those different funding agencies, you do have to do a 2-step to figure out how are you going to respond to their requests for data. Financing for hardware, software, and training and competent expertise is certainly critical to providers. Inadequate governance and management leadership in many organizations, both in for-profit and nonprofits, unfortunately, and after the 2008 recession, we've come to appreciate many nonprofits about how that puts us in positions of vulnerability. We, like many agencies, had to deal with staff computer literacy, and many of us have smartphones here. But back in 2006, the population who were providing care for persons with a substance disorder tended not to have access to technology, tended not to know how to use it. Maybe their children or grandchildren knew that, but most of the providers, line staff, did not know how to use it. And finally, we have these confidentiality laws. We all have HIPAA, but in substance abuse treatment, we have 42 CFR, which makes it even more challenging to share information. As a physician, I find it unfathomable that I have a patient that I cannot get access to information that has a difference about whether or not I can use various interventions. To me, this hurt. I do understand the issue about privacy. I understand the issue about stigma. But aren't we enabling it to continue to say we want to keep this separate and hopefully as equal? I think not. That's my opinion. Funding, how we resolved it, I mentioned to you that we received this grant from NIDA to evaluate electronic medical record. So we went to our board of trustees and said, hey, we're going to have to give the money back if you're not really ready to put some money in the pot. In addition, at the same time, in New York City, the good mayor, is currently mayor, actually decided that he wanted to have some assistance to help healthcare providers to be able to communicate with each other. So they provided some funding to help as well. I believe that the regulations, the Affordable Care Act, will actually help to stimulate this because of the fact that we're going to need to be able to gather more information in a timely fashion to meet with and provide information to the health exchanges. For us, it also meant retaining external expertise. What you say, why would you do that? Well, within any organization, what they say, politics is all local. And in any agency, there is some politics, and sometimes you need to bring in external consultant to tell you about how you are doing things and how you're not, and opportunities you have, and going forward from where you are to where you would like to be. Is it, in fact, a minor issue? Is it you feel it's an important issue? Depending on where you place it will determine how effective it will be to help you solve the issues. For us, and the issue about electronic security, quite frankly, we did not know the vulnerability that we had with respect to the documentation of the information that we had about our patients. Many of our counselors would in fact tell us, you know, I'm going to take this note home in order to finish it because I can't finish it during 9 to 5. We would tell them, oh, you can't do that anymore. It's got to be there. And the issue about communication collaboration. Like many agencies, we are about $20 million, about 250 employees across 10 different programs. That's a level of complexity that you have to make sure that everyone is on the same wavelength. So here are my recommendations. One, I think that if you're going to embark on this, you need to understand that the relationship between management and staff will evolve. In the past, before we had this, we couldn't quite tell what was happening in many of our clinical settings. Once you have it, you have to do something with it. So the relationship will evolve. It's going to be also important that you identify your processes before you bring in the technology. To assume that the technology is going to cure flawed processes is a fallacy. It's only garbage in and garbage out. Quite frankly, the return on the investment requires some difficult decisions from management. How are you going to use this to make sure that you're able to be competitive and effective? For us, quite frankly, because of the economic downturn in 2008, because of the reduction in government funding, because of the fact that we had to adjust, we, like other nonprofits, had to let go staff. And we had to use the technology to help us to respond to these additional challenges. To the payers, my suggestion to them, only ask for what you need. We have this knack of asking for information that we can hardly use. Offer financial incentives to enhance technology use. And I must confess, even though there's still a spirited debate, I align on the side of pay for performance. I think you have to have a way to incentivize your providers to do good and to do well. Regulating agencies, I think we need to resolve the discrepancies between state and federal in terms of how they collect data, because only the little guys, the providers, are going to be suffering from it if there's not. And we need to focus on outcome measure. I certainly agree with that. The question is which ones to choose, and use your system to help you identify whether you're getting there. I mentioned about financial incentives to the providers. Have an effective dialogue between government, payers, and providers. And we need to really grapple with this confidentiality versus quality of care issue, access to information. If we don't, we're going to continue to have this separate approach, and it's only going to further hurt those, in fact, who need it so desperately. And I think... Ooh. Oh, one thing, 1 second. Okay, I forgot. There's two other reasons why an EMR is important. One is the fact that many of you heard of the National Drug Control Strategy, and there's been a recommendation that they're linking between the EMRs and the Prescription Drug Monitoring Board. Well, if you don't have an EMR, you can't link with the Prescription Drug Monitoring Plan in your state. The other last and important thing, I mentioned research at the beginning. EMRs allow you to, in fact, have greater interventions with respect to biomedical and behavioral research, to both generate hypotheses and actually answer hypotheses using observational study designs. With that, thank you very much.